If you've ever had a wrist pain or hand pain, there's a decent chance that you've heard either DeQuervain's tenosynovitis or trigger finger. Those are the topics we're going to talk about in the podcast, so let's dive in. So let's dive into DeQuervain's tenosynovitis first, and there are a couple other names for this. You may hear things like gamer's thumb or mother's thumb or new mom's wrist. All those are the same thing. They all mean DeQuervain's tenosynovitis, but it kind of just is giving you a little teaser of what might cause this. Repetitive use type things like gaming or having a new baby. So if you see those things, they're referring to DeQuervain's tenosynovitis. Let's talk about the incidence first. So overall affects about 0.5% of men overall and 1.3% of women. And women are about 2.6 times more likely to be diagnosed with it, where the peak incidence is between 40 and 59. I will say I tend to see this skew a lot younger. That's my general population. So it does happen quite frequently people younger than that, because when you talk about new mom wrist, and a lot of times new moms are younger than 40. And so just keep your eyes out for that. It does not have to be like, oh, like they're 20 or 30. Like it can't be like, no, that can happen pretty much at any time. But peak incidence around 40 to 59. From an anatomy perspective, we're going to talk about anatomy because everyone loves anatomy, right? But it's important to know so we can understand that. Here, this picture we're looking on the video is there's 6 dorsal compartments of the hand. So when I say dorsal, I mean the back side of the hand. And you can see there's a lot of extensor tendons. Some people say the extensor compartments, dorsal compartments, all the same. Here you can see they all kind of go there and travel in the back hand, the dorsal side of the hand. And there's 1, 2, 3, 4, 5, 6 going from radial on the thumb side to ulnar on the 5th digit side. So radial to ulnar is how we count them. And you can see there's just a lot of tendons. Specifically, DeQuervain's is dealing with this first dorsal compartment. So this is the abductor pollicis longus and the extensor pollicis brevis. The way I think about that is an apple with extra peanut butter. So APL, abductor pollicis longus, and extensor pollicis brevis. Not that you have to know the names of all of them, but you may see it on an exam or something like that, or you just want to know a cool party trick to share with your friends. But that's what we're seeing here. And as we're going down, what you can see here, this is very radial side, right? So kind of going right over that first digit in the thumb, right over the dorsum here into the radius, right on that radial side. This is where we tend to see this incidence, is this first dorsal compartment. So that is DeQuervain's in terms of anatomy perspective, what we're looking at. After anatomy, the next thing we want to talk about is pathophysiology. So what's actually going on here. And if you can kind of break it down here, we're going to break down, this is a tenosynovitis, right? So tenosynovitis. I think breaking down words can be helpful. So tenosynovium actually is the connective tissue and fluid between the tendon and the sheath. So there's this tendon here, and then there's the sheath surrounding it, right? Then we have stuff in between there. That's the tenosynovium, kind of what's in between. And typically what we're seeing here is we are seeing a swelling or thickening of that area. And I kind of just want to bring home the point is when I hear swelling and thickening, a lot of people think like inflammation, right? It has to be inflammatory. That doesn't necessarily seem to be the case here. It does appear like under histology, it's more degenerative and not inflammatory. And this might sound familiar because that's actually what we find a lot in chronic tendinopathies, is that we see a thickening of the tendon, but it's more degenerative. So we have this thickening, and it may be easy to think like, oh, like we have to have inflammation, because you may see some swelling on exam and on that person's wrist, but it doesn't necessarily mean that it is inflammatory in nature. It might be more degenerative. Jury's still out, still always finding new things, but that tends to be, what's going on there and what we're thinking about it. But it's not necessarily, slam dunk, and it doesn't really matter that much. If you think of it as inflammation versus thickening, it's not going to be a huge difference in terms of treatment. The reason we care so much about tendons is because it kind of changes treatment. Here, it really wouldn't change treatment. But just for completeness and where the current literature is, that's what our general thought is. But it's this, tenosynovitis, this tenosynovium gets thickened. And then moving on from pathology, next we're going to talk about risk factors. Different risk factors: repetitive wrist use or manual labor work, radial or ulnar motions of the wrist, pregnancy, too much smartphone use. I actually saw an article talking about people who are just on their phones too much, constantly. That may lead to having DeQuervain's, which is super interesting, but there are some case reports on that. But overall, the general theme is this repetitive use, right? Someone who does manual labor, who is using their hands a lot, things that are moving all around in lots of range of motion. Those are kind of the things we think about from a risk factor perspective. And we think about the presentation. Typically, the presentation is going to be pain on the radial wrist along the course of those extensor tendons. So when you think about on this side, right, on the thumb, this extensor tendons right here, that's where it's going to be more in this kind of radius on the radial side. Maybe they have worse with thumb movement. They might be moving around saying it hurts when I do this. They have some sort of repetitive use, and then maybe pain with ulnar deviation or radial deviation, specifically, moving them around. They have pain with that thumb and wrist. And a lot of times it's really the history, right? The most important thing is getting that good history. One classic example you think about is a new mom, right? Like, hey, I just had a baby a couple weeks ago, maybe a couple months ago, and there's have a new load. They're just carrying a baby all the time. That's a lot of use in those tendons. One example that I had was a patient who was in the military, just got out, so hit retirement, and was like, hey, I'm gonna take it easy for a while. And he's just like, I'm playing video games nonstop. So he was playing video games like all the time. And then on top of that, he like moved. And so he was like just using his hands all the time. And that was just like that exacerbating event. And so get a good history. It's going to go away. Pain on that radial side and right around there. That's what they're going to say. That's where it hurts typically. On a physical exam, what we're going to do for physical exam is they might have tenderness palpation over the first dorsal compartment, maybe some swelling, and then a positive Finkelstein where when we're thinking about Finkelstein, what we want to think about is they're grabbing that wrist and you're passively bringing them through. So passively bringing that ulnar deviating that wrist. That's the Finkelstein's test. And when you're palpating right there on the wrist, they may have pain. Also, you might see a little bit of swelling as well. Some literature that I've looked at talked about maybe feeling some crepitus. So not that you should be terrified from crepitus. Obviously, crepitus is not a normal thing to feel, but if you kind of have that constellation of no acute injury and some little bit of crepitus on the exam with dorsal compartment tenderness and all that stuff, it kind of adds up. But the big things is if you're hitting Finkelstein's test, that's going to be really kind of the big one there. And from a physical exam perspective, we talked about that. Now, imaging, what we do not need to do imaging to make the diagnosis. That's like kind of the big take home point is you don't need to do anything. You don't need to get x-rays. Those are pretty much unhelpful, right? If we're worried about a tenosynovium issue, that's not going to show up on x-ray. So not helpful. Ultrasound is probably our most practical, and you may see some swelling and just extra fluid in that sheath. That's a very common finding in ultrasound. You'll see that, or you might see thickening in that area. I would say if you have the skills, ultrasound is all you need. It's more than enough. You can make this clinically. You do not need this. In primary care, you don't need this, but ultrasound's always fun to see and look at. But so that's probably the most useful and practical. And then MRI is maybe needed for refractory cases. Like that is not normal. In the vast majority of times, you're going to see that and be like, that's DeQuervain's, and then you can treat it accordingly. So you do not need to have an MRI by any means. But if things are, you're treating it as such and it's not getting better, then that's, kind of when we think about that. But that is certainly not anytime soon in the treatment algorithm or diagnosis algorithm. You can give that a little time. From a differential perspective, we want to think about a couple things. Intersection syndrome. This is kind of like the cousin to DeQuervain's. This involves the crossing over the first and second dorsal compartments. That's a whole other discussion and talk, but it can be very similar. It's a little more proximal though, so you get that. CMC arthritis. This is really close to the CMC joint of the first digit, right? So we may see some arthritis there. If we have a scaphoid injury, they always talk about snuff box tenderness. This is right one of, this compartment makes one of the borders of the snuff box, and so you want to make sure it's not a scaphoid injury. And then also radial nerve kind of hangs out there as well. We might have compression. So those are the things we think about. And then from a treatment perspective, there's number one is stop the inciting motion, right? So if someone's consistently irritating at doing something, saying, hey, like I'm playing 12 hours of video games a night. Okay, like cool. That's a low hanging fruit. Let's start there. So stop the inciting event or motion. One thing we can also do is put them in a splint or a thumb spica splint. So thumb spica is going to immobilize the thumb. That's very important. Please don't just put these people in a normal wrist brace, because when you put someone in a normal wrist brace, it's just kind of around the thumb. They can still move the thumb and it's no problem. Whereas a thumb spica is going to immobilize that thumb, and that excessive thumb movement is kind of what bothers people. So put them in a thumb spica, not just normal one. One thing you can also consider is a steroid injection. And this kind of goes against most things that I teach, like steroid injections. We want to be cautious and we always want to be judicious. And usually I'm like, that's not the answer. This time it actually may be the answer. There's been multiple studies, and a meta-analysis showed that steroid injection had better resolution of symptoms compared to placebo being either splinting or a placebo injection or acupuncture. And that was 84% resolution to 31%. That is pretty strong. And another study I showed that maybe even doing injection plus splinting might be better, but the common denominator here was we had really good success with injections. Now, I'm not by any means saying you have to get an injection, right? If you have a patient come in and say like, no, I don't want to do an injection, don't pressure them into it. They can try these conservative things. We can try splints. It's very reasonable to do. If you decrease how much you're using it, offload it a little bit, get some splinting, that's totally reasonable to try. Maybe get them an occupational therapy potentially. You do not necessarily have to have an injection or surgery. It just seems to be that you get quicker results with a steroid injection. It tends to lead to decent long-term outcomes. And so this is like one of the very rare instances where I say like a steroid injection might be reasonable to do. Now, once again, same rules apply. We're not doing repeated ones over and over and over to weaken the tendon, but this is one where it can be curative early. And that's the big thing, right? So when we're thinking about injections, A lot of times we're just doing steroid and it's just like kicking the can down the road. Like this is not necessarily doing that. This may just be enough to calm it down and actually can be curative, and it may not come back for people. So for me, that's like the litmus test of, okay, if I can do an injection and they don't have to get another one and maybe curative, then that would be a very reasonable reason to do that. But this is one instance where the data seems to show it may be helpful. And if you're doing all that and then it's not working, surgical release is then going to be the definitive treatment. And you're doing a release of that first dorsal compartment, and success rates that I've seen in literature up to 91%. So can be very, very effective as well. And so to land the plane here for DeQuervain's tenosynovitis, we'll just wrap it up with a summary here. This is an insidious onset radial sided wrist pain, and it is a tenosynovitis. This is what we think about. It's exacerbated by excessive thumb movements, typically seen in women. And think about pregnant patients, or new moms, I should say, when they're having babies and holding baby for a really long time, that may present like that. The exam is going to have maybe tenderness over that first dorsal compartment with a positive Finkelstein test, and we treat with either immobilization or steroid injection. And then if it's refractory, not getting better, then we can consider surgery. So overall, that is DeQuervain's tenosynovitis. Not a whole lot going on there in terms of, it's not the most complex thing in the world, but it can be very debilitating for patients sometimes. They can have a lot of pain. And so we can do a lot of good by helping people out, understanding what it is, how to treat them. So let's move on then to trigger finger. So first and foremost with trigger finger, let's talk about the incidence. It affects about 2% of the general population. About 20% of people with diabetes have this, and it's usually around the ring finger. And we'll talk about what's actually going on there, but I just want to point out that huge discrepancy there. So 2% of general population, 20% of people with diabetes. So obviously diabetes is a very big risk factor here, but we're still seeing it pretty darn commonly. We have a lot of diabetics in clinic, and if 20% of those people are getting this, then we're going to see a lot of people with trigger finger. From an anatomy perspective, let's talk about it here. There are flexor tendons and pulleys. So these tendons go through these pulleys to help kind of keep them down, right? So if you think about it from a perspective, if your hand is, if your tendons are here, right? They're right in here. And if you didn't have these pulleys keeping them down, like you would start to have tenting of your tendons there. So it would look really weird. So the pulleys are all throughout the finger, kind of keeping the tendons down and helping them slide easier. And there are multiple pulleys in different spots, but for this specifically, most commonly is A1 pulleys involved. And so if you kind of look in the diagram here, we have these pulleys, which are kind of these semicircular fibrocartilaginous structures that are just kind of keeping the tendons down. And this is the normal anatomy. And in trigger finger, we have an abnormal issue there. We usually have thickening or a nodule or something like that. But this A1 pulley specifically is right around the metacarpal head. That's like where we're generally thinking for the A1 pulley. So anatomy wise, there's multiple pulleys, but for this A1 pulley, so right around metacarpal head, that's where we're thinking specifically. And moving on to pathophysiology, essentially this is another tenosynovitis, but this one is a stenosing tenosynovitis. So like we talked about before in previous lectures, is that a tenosynovitis, the tenosynovium is kind of the area between the tendon and the tendon sheath. All that stuff, it's in there. And what we have here, we have a stenosing tenosynovitis of the flexor tendon as they pass through the pulley, which is usually that A1 pulley. What I think about is the flexor tendon gets either bigger relative to the pulley and creates a irregular connective tissue, and then it leads to kind of proliferation of the chondrocytes or the tenocytes within the annular pulley, and it leads to essentially a bigger tendon that's harder to move through. That's kind of how I think about it. It causes a mechanical obstruction during flexion or extension of the finger. And kind of 20,000 foot view is the tendon's either too big or the pulley gets narrowed down. So it can be a combination of both of those things. And so if you look at the diagram here, you can see early we kind of have a little bit of irritation of the flexor tendons. This is that normal A1 pulley. Whereas if you see advanced trigger finger, just see how much more thickened the tendons themselves are, how much more thickened kind of the sheath and tenosynovium is. And so that's what I mean by could be either. When I say that we're getting this thickening, this is generally what we see, is thickening either at the tendon or the tenosynovium or around there. So we're either getting trapped from a nodule, so you can have an actual definitive nodule that's like, obviously there's only a certain amount of space to go through and the nodule is going to be hard to go through. So you feel that trigger, that's what's going through, or you can just have thickening in general and just makes it difficult. So it's either too big of a tendon or too narrow of a space. And that's what leads to this kind of triggering response and kind of how it feels in that finger. So risk factors, like I mentioned before, diabetes is a big one. Other things are repetitive use, excessive gripping, female sex seems to be a risk factor, but the real thing is we don't really know why this happens. And that's one thing, if there's no definitive reason for like, hey, this is what causes trigger finger, but it's just something to consider that these are risk factors occasionally, but not necessarily, hey, everyone who uses their hands a lot gets it, but diabetes, repetitive use, things I think about. From a presentation perspective, early you might have some subtle pain around that A1 pulley site, which is right in that distal palm, right around the metacarpal head specifically. You might have some crepitus with range of motion when they're moving their finger through flexion extension. Also, you may have a palpable nodule along the tendon. So what you may do is kind of right here when you're moving, you might have a little tenderness right on. That's kind of the spot here, the metacarpal head. And then late tenosynovitis or trigger finger may have an inability to fully flex or extend the finger. You can have locking of the finger and flexion, painful popping in fingers with flexion or extension, and oftentimes worse in the morning. So a lot of times what patients will say is like, yeah, I wake up in the morning, it's stuck like this. Like they can't, literally have to manually unlock it. So that's a pretty, if someone's telling you that, that's pretty classic there. But on exam, when they have a late one, you might be able to feel that. You might be like actually like have them, okay, what you'll do is do it a couple times and you'll feel it. So it can be very, very impressive. But if they say it's locking, diagnosis is pretty obvious there. From a physical exam perspective, you can do some palpation. You might have tenderness over that A1 pulley. You may be able to reproduce that locking or catching on exam, but it may be unremarkable as well. So that's the thing. Sometimes the history is very strong when they do it, but it's just, it's later in the afternoon and it doesn't happen as much. So if they say that, hey, I have this all the time in the morning, I get up, it's like this, it's locked out, I can't do anything, you can still make the diagnosis. But it is really an impressive thing when you are trying to get them through. A lot of times I'll just have them actively do this, and then a lot of times you'll feel the clunk, clunk, clunk. You'll feel the catching or the clicking, and that's kind of cinching the diagnosis there. From a physical exam perspective, it's not too much, but if you can feel it catching, popping, that's pretty awesome. Imaging perspective, you do not need imaging to make this diagnosis. Once again, just like DeQuervain's, you do not need imaging. X-rays, largely unhelpful because this is a tenosynovium issue, so we're not going to see that. Once again, ultrasound, probably our most practical exam for this. You may see increased swelling. A lot of times what you see is thickening potentially of the tendons. You might see thickening of that tenosynovium, so you see more fluid in there. That is a telltale sign that we have some sort of irritation going on there. And once again, MRI can be used for refractory cases, but that is not what we normally need to do. Usually this can be a clinical diagnosis. You can make this in clinic. You do not need imaging, but those are some modalities that may be helpful. From a differential diagnosis perspective, we may have some MCP joint arthritis, you could have a volar plate injury, you could have some sort of tendinopathy of one of your flexor tendons. You could also have Dupuytren's contracture, which is different. That one typically we don't have improvement on when we're gradually getting, usually that's kind of a fixed contracture, but something to think about. Or maybe just have manifestations of carpal tunnel syndrome. From a treatment perspective, very similar to DeQuervain's. First thing first is we're going to stop the inciting motions, right? So trying to minimize repetitive gripping or pinching, things like that. You can also do some splinting. So you can put the finger, you're trying to avoid full flexion. So splinting either the MCP or the DIP in extension, with the MCP usually better. So if we look at it here, MCP, metacarpal phalangeal joint, if you're putting this joint right here in a little bit of extension, keeping extended, that's the goal, or the DIP, which is out here. A lot of times a little more well tolerated at the MCP, but we're trying to avoid that full flexion. That's typically what we're going for there. Another thing we can do is a steroid injection, and similar to DeQuervain's, there's some decent results here with this. We might have a one and done situation. When I mean one and done, I mean sometimes when we do this injection, it's actually curative, meaning people don't have to come back for more and it gets okay, but it's not as highly effective as the DeQuervain injection. One study like that was about 57% effective. Other ones kind of around that area, and that's complete resolution of symptoms, which is great, but it's almost a coin flip, so it's not fantastic. And these were landmark based, however, so probably would be a little higher, I imagine, if we did it with ultrasound guidance, but it's still not fantastic, right? It's not like, hey, 100% of people. But once again, in this situation, I don't really do a lot of steroids unless I feel like the risk reward's there. And the reward, if we have a curative thing, that's fantastic. It's not the most comfortable injection because it's going in your hand, but if we can make it curative from one injection, that's a reasonable thing to consider. Typically we can do up to 3 injections after that. Usually we start getting a little worried that, okay, those are repeat injections right around tendons. We don't want to increase the risk of rupture. So usually 3 is what we'll go for. And if we do steroids, we have to think about specific steroid side effects like fat necrosis and skin depigmentation because we're so shallow in this. So just something to consider. And however, if we're doing things and it's not getting any better, then we can do a surgical release. They just release the A1 pulley, and it looks like it does seem to have better outcomes and less recurrence than steroid injections. And I should mention these procedures now are done in offices. So this is no longer I have to go back to the OR, get full, get anesthesia, anything like that. A lot of times it's just local and they can do it there in clinic, which is pretty cool in a procedure room. So way cooler procedures now, not nearly as bad, but still a surgery and you're out for a little bit of time. And so just something to consider, but it does seem to have better outcomes and less recurrence than steroid injections for trigger finger, but kind of talk with your patient all about that stuff. So To bring home the take-home points for trigger finger now, this is an insidious onset stenosing tenosynovitis around the A1 pulley. Diabetes is a big risk factor for this. These patients are going to complain of pain around the metacarpal head at the A1 pulley, also complain of maybe catching or locking. We're going to diagnose this clinically. You don't necessarily need any imaging, and we can treat it with splinting, injections, or if needed, surgery. So hopefully you found that helpful. And that is going to do it today for the podcast. Thanks so much for stopping by. I really appreciate it. If you found today's episode helpful, and it would mean the world if you shared this with a friend or left a 5-star review on your podcast platform of choice, that would really, really help the show grow. And if you would never want to miss a piece of content, consider signing up for my mailing list, which is linked in the description below. I'll send out content every time I release it during the week, and I promise never to spam you because I hate spam just as much as you do. But that's it for today. Now get off your phone, go be active, have a great rest of your day. We'll see you next time.